Question 6, Mr Speaker.
Thank you, Mr President. I beg to ask the Minister for Health and Social Care who was consulted prior to the announcement of the suspension of elective surgery.
On the Minister to reply, Mr Ashford.
Thank you, Mr President. The suspension of an element of elective surgery was an urgent operational decision taken by the executive team in DHSC on Wednesday the 25th of November. This was in line with the immediate bed pressures, including patient transfer repatriations from the UK due in the coming days, plus the increasing number of staffing issues the department has been facing. In order to create immediate acute medical capacity, the operational senior management team and a number of the executives discussed and agreed the actions needed in order to keep patients safe. This included a focus on discharge flow and the reduction in planned inpatient activity and a shift to day case activity in trauma and orthopaedics. The position was supported by the Director of Nursing and the Medical Director. Our operational teams on site at Nobles during the forthcoming 24 hours were then briefed. Initially acute physicians to reflect the immediate acute medical admission pressure, and then with the surgical team in readiness for their planned inpatient lists. The operational day-to-day rhythm includes patient flow meetings, medical take handovers, safe start meetings where business managers and ward staff in each care group triumvirate operate. They then communicate with their care groups, including all clinical teams, at the first available opportunity. After the immediate safety issues were addressed, a final programme to document the change around elective inpatients to elective day case activity was then agreed with the DHSC executive team and at the earliest departmental meeting thereafter. This programme included input from the senior clinical leaders within the direct surgical teams affected. An initial review will take place on the 4th of January. Decisions of this nature are not taken lightly, but not uncommon in periods of peak demand, particularly around winter, amplified this year with the position around COVID self-isolation and the current pressures around workforce. Thank you, Mr President.
Speaker.
Thank you, Mr President. Can the Minister confirm that the consultant orthopaedic surgeons were not actually consulted until very much the last minute after it had been announced publicly? Does he regret this, and does he see the need for any changes to procedures?
Minister to reply.
Thank you, Mr President. The clinical directors, I believe, were involved in the decision, who should have communicated it to their teams. I have been contacted by one of the orthopaedic consultants to say they were not aware and they learnt of it from the public announcement, which from my point of view, Mr President, is completely and utterly unacceptable. I have asked the Chief Executive of the department to go back and check who knew what when, because I have made very clear since the day I became Minister of this department that we need to have a culture of openness, and one of the key lines of communication has got to be the people on the ground know decisions before they are publicly announced.
Honourable Member Mr Shermans.
Thank you very much, Mr President. Can the Minister confirm that the suspension of surgery was not due to a shortage of beds, but rather it was a shortage of medical staff to man those beds? And given that the department, it would appear, is struggling with ongoing staffing challenges exacerbated by the border restrictions, can we expect further suspension of procedures? And what does this mean for those people who have been waiting for years on waiting lists? Thank you.
Thank you, Mr President. I'll take the last point first, which is no, we don't at the moment expect any further restrictions on procedures. The winter plan is up and running. We are now, with trauma and orthopaedics, focusing on the day cases, so we are dealing with some of the trauma and orthopaedics to get the lists down on the day cases. In terms of the issue being around staffing rather than beds, it's actually a mixture of the two, Mr President. So, for instance, I can give the Honourable Member an example. So if you look, for instance, at the bed occupancy on the 1st of December, the general surgical beds, the bed complement's 20, beds occupied was 20, elective surgery, bed complement 21, beds occupied 21, and orthopaedic itself, even with the suspension, 16 beds, 14 occupied. If we turn to medical, you've got acute medical, 20 beds, 16 occupied, medical and elderly, 21 beds, 20 occupied. So there is clearly issues around bed pressures, but there is also staffing issues, Mr President. That's not just due to the border restrictions, that's due to the fact that we have seen a high number of patients that require one-to-one care as well within the hospital, and that has put pressure on delivery of services. And equally, Mr President, in the UK at the moment, with the situation they're experiencing in their NHS, they are swallowing up an awful lot of temporary staff and are increasing pay rates accordingly.
Honourable Member Miss Edge.
Thank you, Mr President. I wonder if the Minister would mind, probably if you haven't got the information, circulating it, but if you could give the definition of what elective surgery is with orthopaedics, and also if you could circulate the current waiting lists for elective surgery and for day cases. And surely under bed management, if you're turning over day beds, surely there's people that have been waiting possibly up to 3 years for orthopaedic surgery. Where does the priority lie? Thank you, Mr President.
Mr Ashford.
Thank you, Mr President. I can answer those questions right now. The first thing I can say to the Honourable Member is in terms of elective surgery, what we're classing as elective surgery in this instance is those that require an overnight stay. So it's those that will actually require an overnight stay in trauma, in orthopaedics and trauma. In relation to day cases, there's currently 196 on the list. 5 of those urgent and 191 routine. In terms of inpatients, there is 364 on the inpatients list. And apologies, Mr President, I managed to lose the page. And in relation to those, on the inpatient list, there's 44 urgent and there's 320 that are routine. In terms of the Honourable Member mentioned about waiting times, the average days waiting across the entire specialty is 262 days. But we have to remember that's an average, Mr President, and obviously cases will be dealt with according to their priority both on urgency and length of wait.
Final supplementary, Mr Shimmons.
Thank you, Mr President. Can the Minister advise, have any beds or wards been taken out of service at Nobles Hospital? And if so, how does this impact on the bed availability statistics which she has quoted?
Minister.
Thank you, Mr President. In relation to wards, yes, Ward 12, I believe, is the one that has been taken out of service because we have reprioritised staff elsewhere. In relation to the impact of beds, the impact on taking out Ward 12 is 15 beds, Mr President. But I do need to point out that the orthopaedic figure I gave before for beds is actually in relation to Ward 11, not Ward 12.